Welcome to AETCM. Today we are going to discuss a case about a 40-year-old female who came to your ER with complaints of fever with myalgia for the past 6 days. Can you begin, sir?
Yeah.
Sir, on initial assessment, the patient was conscious and oriented. Coming to the airway was patent and there was no secretions and the C-spine was appearing normal. In the breathing, air entry was bilaterally equal, but she was having a respiratory rate of 30 per minute with a saturation of 98% in room air.
Okay.
And here itself, she was having a tachypnea. Initially, we tried to give her a O2 support to reduce the tachypnea.
So my question here is that when you check the saturation is 98%. Why you want to supplement her on O2?
Because she was having tachypnea. To reduce the tachypnea, O2 support.
See, the tachypnea reason could be due to metabolic acidosis. It could be something else. So the answer will be you want to decrease the respiratory effort, but by giving oxygen for this patient, we don't know, maybe for a patient who is having a desaturation or saturation less than 95%, we are justified to start on oxygen. But otherwise, with a 98% saturation, no need to start on O2. You can think of starting something else like an NIV, maybe for time being, for that the respiratory effort can be decreased. So as soon as the patient arrives to the ER, maybe due to anxiety, due to multiple reasons, there can be tachypnea. I'm not saying about this patient, but whenever there is a decrease in oxygenation, less than saturation 95%, then you are justified to start on oxygen. But otherwise, just for the respiratory rate initially, it will not be advisable because not for all patients. So whenever you target, if it is less than 95, you start on O2. Otherwise, you do the full complete evaluation and then you see that, okay, chest is clear, there is nothing else. Then you are thinking of a metabolic acidosis. Then you can try for a non-invasive ventilation support to decrease the effort. The problem, what will happen, they have persistent respiratory rate of high, like 30, 35 for a long time, their effort will come down. Then slowly the PCO2 will start building up. Then they will go to type 2 respiratory failure. So that you can prevent by putting up into an NIV will be ideal. But less than 95, you start O2. Okay.
And here it's following which circulation, your BP was 140/90 with peripheral pulses all palpable and pulse rate of 70 per minute.
Okay.
And in disability wise, GCS was full score and pupil were bilaterally equally reacting.
Okay.
In exposure, temperature was afebrile and GRBS was 173 milligram per deciliter.
Okay.
Coming to the adjuncts, we did a ABG. ABG was showing 7.30 pH with PCO2 of 45 and bicarbonate of 21.
Okay. So what is the acidosis? What type of acidosis she is having? What is the bicarbonate?
Bicarbonate 21.
21. So what is the expected PCO2 if you take it as a compensated or a partially compensated metabolic acidosis?
Expected PCO2
maybe 21 into 1.5. 21 plus 10 you can take 31 plus 8. 39 plus or minus 2. But as you said, there is some PCO2 built up also. So that she is going for an impending type 2 respiratory failure. Slowly the PCO2 have built up. Now the oxidation will start falling down. So at that time she will be beneficial with putting an NIV rather than just giving an oxygen delivery device. Okay.
And here in this point we put her on NIV.
Okay.
And for we also did an ECG also. ECG was showing normal sinus rhythm with heart rate of 69. And for
heart rate of 69. So somebody is coming with a respiratory rate of 30 and quite tachypneic. You are getting a heart rate of 69. You think that is normal or you think any pathology at this point of time?
Some fever with relative bradycardia.
Okay, usually what should be the picture? They should be having some amount of tachycardia, but she is only having a 69 heart rate, which I am not having. You say relative bradycardia, one thing that you can think of. Then what else you can have in a fever with similar pattern? They can have myocarditis, they can have heart blocks, conduction abnormalities, and other thing that you need to keep in mind, whether she is already a hypothyroid patient, already on beta blockers, calcium channel blockers. All those things you should keep in your mind. But heart rate of 69, we are not expecting. And otherwise 7.3 pH. What else it can be? It can be in hyperkalemia. So hyperkalemia and metabolic acidosis, which is resulting in a probable conduction abnormalities relating. So 69 heart rate, we are not happy. Maybe 100, 110 is what we are expecting at this point of time. But 69, you should have always, you think it is in the normal range, but this patient, from whatever history that you are giving, from what we know, that her heart rate should be high because she is anxious, she has come to the ER, she is breathless, you are initiating her NIV, and heart rate is only 69. We have to chase that why there is a bradycardia. We can, definitely you cannot say it is a bradycardia, but for her symptoms, the 69 heart rate is not a tachycardia. Normal, it can be a bradycardia. Okay.
And further following which we'll go into the secondary survey. Here in the history was...
What is the chest X-ray taken?
Chest X-ray was taken, chest X-ray was showing bilateral mild pleural effusion.
Bilateral mild pleural effusion, okay.
And the secondary survey, she was not having any comorbidities. She was complaining, the main history is that she was having fever, myalgia, vomiting with loose stools for the past 6 days. And she went to a nearby hospital, and wherein which she was found to have thrombocytopenia with altered LFT, RFT with anuria.
Okay.
And there she was started on injection ceftriaxone with doxycycline, and for the anuria and whatever maybe because of the VBG changes, one session of hemodialysis was also done
from outside hospital.
And further she developed breathlessness with hypotension, and she was started on noradrenaline support with NIV.
Okay. From this whatever available history and background, we look like a tropical fever. So whatever be to this monsoon season, very commonly we used to see this tropical fever. Among this, most two important one is
dengue and
leptospirosis. So it will have similar findings, but how will you differentiate between an probable dengue and a leptospirosis? What will be your differentiating features? Or before you cannot, rather than saying leptospirosis, we can call it as Weils disease. So it is multi-organ dysfunction is there, not just leptospirosis with thrombocytopenia, organ involvement is there. So how will you differentiate between probable dengue fever and probable leptospirosis?
So mainly leptospirosis clinical features will be showing mainly fever with myalgia, whereas in dengue fever it will be fever with retroorbital.
That's all classical. So any viral prodrome, the presentation will be fever with body pain, myalgia, retrobulbar pain, headache. Both these things will have. But as you said, when you look into the patient and when you just see myalgia is very prominent symptom in leptospirosis, low backache, even in dengue also it is seen. Then what else? Presentation wise. Presentation wise, usually you can see dengue fever, the pattern will be the first 3 days they will have fever. And after fever, they will have some generalized weakness, tiredness, and that fever will subside, and they will have other complications, and sometimes they can recover, like thrombocytopenia may develop, and they can go into recovery phase, and very rarely the patients can go into macrophage activation syndrome. So that is how dengue usually does. Leptospirosis, what will happen? Usually the fever again will last for 1 or 2 or 3, 4 days. Then they will have, depends upon their complication. Some people will go into like acute Weils syndrome. Weils disease they will go for. Otherwise, some people will hold on and they will not go into a Weils syndrome. But usually leptospirosis, they will have both dengue and this thing will have thrombocytopenia, renal failure, common in leptospirosis, not very common with dengue because acute renal failure is very common in leptospirosis. Both LFT alteration, dengue as well as leptospirosis can do, and alveolar hemorrhage, lungs alveolar hemorrhage is more common in leptospirosis. Less common in dengue, but they can also have if the patient goes into a phase called as macrophage activation syndrome. So clinically when you look, it will look similar. It will have, but whenever there is a renal involvement, lung and renal involvement, usually the differential diagnosis favors in terms of a leptospirosis. So that is what you need to keep in your mind. Now you have the patient has come to the ER. She has received 1 session of dialysis. What type of renal, what are the indication of dialysis in such a patient? So we have different spectrum of patients requiring dialysis. In this patient, they have started on dialysis. What could be the reason why they have initiated her on dialysis? 1, 2, 3, 4, 5 reasons.
Main reason can be severe metabolic acidosis.
Okay.
Then electrolyte abnormalities,
hyperkalemia.
Then volume overload.
Volume overload, okay.
Then uremic
volume overload and oliguria we can put together. Volume overload and oliguria we can put together. Then
uremic encephalopathy.
Uremia and uremic encephalopathy. So generally these are all the indication. But acute on chronic and acute, this is an acute renal failure. So creatinine value we are not considering here much. Even if the creatinine is somewhere around like 2.5 or 3, our parameters are more depending upon acidosis, hyperkalemia, refractory hyperkalemia, oliguria, evidence of volume overload, and other features of uremic complications. So depending upon that, we will decide, okay, this patient requires dialysis or not. Because giving a dialysis is the key in this patient. So if it's a CKD patient, I will not be much concerned at this point of time, because he will have holding it for a longer time. His acidosis, everything will be there for a long time. So he will have that compensatory mechanism already in his body. But for this patient, it's an acute renal failure, it's an acute insult. So we should not delay the dialysis. So delaying the dialysis will reach on to further complications. So we should not delay the dialysis. So what could be the reason why she was breathless? It can be one, metabolic acidosis. It can be part, probably we are not missing a pulmonary alveolar hemorrhage, we don't know. Maybe an early ARDS, but oxygenation was maintained 98% on room air. So ARDS we can keep aside. Maybe pulmonary alveolar hemorrhage also keep aside. And she had minimal pleural effusion also. Maybe that would have been attributing her to that breathlessness. So this will be the reason why she was tachypneic. Maybe a fever was there when she came in? No fever.
No fever.
Okay, so that could be the reason, or maybe some pain. Femoral catheter, body pain, myalgia, everything was there. All together was contributing to her pain. Why heart rate was on the lower side? We could get any answer for that? There was any hyperkalemia when she came in? ECG, you said it's sinus
rhythm. And initially she was not having any hyperkalemic changes.
Okay. Maybe it would have been a part of troponin.
Troponin 0.1.
0.1. So it was a little bit on the higher side, but with background of renal failure, it might be the reason why she's having an elevated troponin. Fine. Okay. So such a patient coming to the ER, you are the first doctor who is seeing this patient. What all the treatment management? How will you plan her treatment? You stabilize her airway and breathing by putting her on an NIV. Circulation, there is no issue at present. Now, what you have to go for the investigations. What all you need to have a confirmatory diagnosis. She presented how many days after the fever?
6 days after the fever.
6 days after the fever. So you need to have a confirmatory diagnosis. You should have a treatment plan made to this patient, thinking that these are the possibilities. So how will you confirm your diagnosis of possible Weils versus dengue?
So after 5 days of fever, for dengue we can go for IgM, dengue IgM test. Whereas in lepto, after 7 days we can go with lepto IgM, or else we can, the initial first week itself we can go for lepto PCR test. Lepto PCR blood serum samples will give positive.
So the history of leptospirosis evolved like this. They would say initially it started with dark field microscopy. So that was the first investigation where we can see the spirochetes inside the urine. So you need to take the urine sample and run to the labs, because the before the spirochetes die, you need to visualize that. So that was the first investigation. Later on, there was a culture media, EMJH medium was there. So that again takes a longer time to grow this organism. So that is also out. Now later on it came with IgM. So lepto IgM, the problem was everybody used to check within 1 week of time, and clinically if you feel it is lepto, but leptospirosis test is negative, because the timing is very important. Only after 1 week to 10 days we should see setting an IgM. So that is next important thing. And now since the PCR have developed, initial phase itself we can go for the PCR diagnostics, either from the blood or from the urine sample. We can do the PCR directly. We can get any organism of spirochete and it can become leptospirosis. No, that is the evolution of leptospirosis. So you need to send the investigation according to the timing. So after 10 days sending a PCR of no use, because already the spirochete has caused damage and it has cleared off from the body. So this spirochete is a very tiny organ. So whatever you take antibiotic, the spirochete will die. So that doxycycline or crystalline penicillin is more than enough. So no need of any higher antibiotics. Any smaller antibiotic will be effective against leptospira. So the problem is that the problems that it creates, the complications and the autoimmune process and all those that creates will be the dangerous to the patient. Like causing most dangerous one will be a pulmonary alveolar hemorrhage, which the patient will not survive, because very very rarely the patient will survive following a pulmonary alveolar hemorrhage. ARDS, then all other complications sets in. Okay. So what will be the what all antibiotics we have started for her?
Here we started with the doxycycline, and on initial evaluation here procalcitonin was 8 with the CRP of 300.
Okay. So why we had to add on another antibiotic? That is a problem, because she was in another hospital. She was receiving treatment in another hospital, and she has come back to us with the evidence of another bacterial infection with an increased procalcitonin. Even in Leptospira, procal can be high. But the problem here is that she has been referred from another hospital. So we need to think of a gram-negative organism causing problems also. So we have added on a gram-negative coverage also for her. So that is why piperacillin tazobactam was added to her. So piperacillin tazobactam with doxycycline. For leptospirosis, doxycycline is enough, more than enough. But she had an added, supra-added bacterial infection. We were covering it with piperacillin with tazobactam. Then what was done for her in the ED?
So for further, we are sent for the investigation to rule out dengue bar lepto, and we started with antibiotics. And on further progression, we sent for the routine lab investigation, which showed a creatinine of 6.94 with urea of 135, and total count was 20,000 with platelet counts of 42,000. So initial day we started on antibiotics. On the next day, her VBG become worse. Acidosis increased, metabolic acidosis increased, and bicarbonate reached below 10. And again we started her on HD. Total 4 sessions of HD was done, and by that time her breathlessness was reduced, and hypotension was also corrected, and we know her of NIV and noradrenaline.
So the pattern of what renal failure, what you are seeing, is something called as an acute renal failure, and most common reason for an acute renal failure is acute tubular necrosis. So the pattern will be, there will be an insult that is happening. So within next 24 to 48 hours, there will be oliguria, maybe reaching to anuria, and all the metabolic acidosis, everything will start sets in. And usually you support the patient with dialysis. For the next, usually the acute tubular necrosis, within couple of weeks, it will subside, and then the phase will be a polyuric phase. So initially, to start off with, you will have this hyperkalemia and all those things. Then later on, you will have a polyuric phase where the patient will have more of hypokalemia. So that will be the presentation. So that is because that is a pattern of acute tubular necrosis. Usually an ATN develops, that will take time. At least 4 weeks is the time that usually set, but within 2 weeks itself, we will start seeing the difference. The patient slowly, the urine output will start increasing. It was 2000 ml, it was 500 ml initially, now it is 1500, 2000, 2500. The excessive output will be there, and also you will start developing hypokalemia, because that reabsorption capacity of the kidney is lost. So that will take another 4 weeks to recover completely. So that is a pattern that we commonly see in all these tropical fevers, is this acute tubular necrosis. So we should be correcting initially hyperkalemia. Now later on we have to treat hypokalemia. That is a usual pattern that what you will see. So then you can confirm that this is a pattern of acute tubular necrosis. So the initial phase, you need to support them with dialysis, maybe alternate day, once in 3 day dialysis. That is what you want to tell the patient or bystanders. They are very keen that whether the dialysis need to be continued. So those questions you can answer like this. You can have a maximum time from 2 weeks to 4 weeks. By the time it improves, the patient will be okay. But if it is not improving, you have to think of other things. Any role of steroids in this patient? What will be the role of steroids in this patient?
Immune-mediated platelet.
Macrophage syndrome, activation syndrome, HLH, you definitely yes. ARDS, pulmonary alveolar hemorrhage. Maybe that immune phase, maybe you can give, maybe methylprednisolone or dexamethasone, but otherwise routinely it is not indicated. So that is what the most important thing, that you should not miss the diagnosis. You stabilize ABC and you require dialysis the patient will stabilize. So the first 3 to 4 days is the key in the management of a patient with leptospirosis. Anything else that you need to add?
Here that our PCR test came out to be positive. For lepto.
Okay.
And after the HD sessions and weaning off of NIV and BiPAP, she was stabilized and discharged.
Okay. Anything else that you need to add on? Okay. Fine. So the key point that you need to remember is that the tropical fever, whatever it is, you treat like either lepto or dengue. So that is okay. So that is why majority of this tropical patient, we start them treatment with the doxycycline. Because doxycycline is a one drug that will be very effective against leptospirosis. Even for prophylaxis. Because post monsoon season or floods, there is a high chance of leptospirosis. That is why government is insisting on doxycycline prophylaxis. Okay. Thank you.